Thank you so much, Krista, for inviting me, and it's a great pleasure to be a speaker at this amazing educational event. Thank you so much for organizing it. So I'll be talking about combining MEG, EEG, ECoG, and their unique contributions. I will be talking about that because my background is actually in combined MEG EEG recordings. That was my PhD. And then afterwards, I added ECoG because I worked at epilepsy surgery centers, like Christoph said, at Cincinnati Children's Hospital and Epilepsy Center at Advent Health Orlando, Florida Hospital. So we were performing about 100 brain surgeries a year. You can see here our surgical room and our neurosurgeon, Dr. Baumgartner. So very often I'm asked this question, what method, ECoG, EEG, MEG, is better? Yes, and I would like today to explore this question, and hopefully we will see that each of those methods has a unique contribution and has something very unique and valuable to offer, and that probably we should not ask the question exactly this way. So let's start. I will start with the contributions of each of the methods for diagnostic purposes, for seizure localization, and then we will talk about functional mapping, which is also very important, again, in pre-surgical workup, and then application for BCI, so some guidance for electrode implantation, possibly, and other applications. And then we will touch on some future perspectives. So let's start with multimodal imaging for diagnostic purposes. And again, I always center around clinic, around patients. This is what my research was the whole my life. And you will hear different examples from clinical practice and clinical research. So I love this study because it really helps to demonstrate how all those three methodologies can be utilized and provide unique insights. And it's a clinical study of 5-year-old female who previously was absolutely healthy and developed daily episodes of fright, pain, and uncontrollable crying. That started at the age of 3 around. And she had sudden onset of fearful face, clinging to parents, complaining of pain in her eyes, and it was lasting less than a minute. So something was happening with this girl. Nobody knew what. And a pediatrician made a diagnosis. So if you would guess, you can add this into a chat. What happened? What was the diagnosis, at least initially? So actually, it was panic attacks. So she was diagnosed with panic attacks, and she was given medication, selective serotonin reuptake inhibitors, SSRIs. And the results, and you can also guess and write it into a chat if you would like to. And the results were that there was no improvement, and she still had those sudden onset of fearful face, and so something was happening that we were not able to detect. Even worse than that, there was a worsening of symptoms, and finally she was referred to a neurologist for full evaluation at our hospital with epilepsy surgery protocol. So what does it mean? It means that there are certain protocols how we will be performing MRI, how we will be doing imaging, various methods combined together, and you will see what it entails. So just very specific evaluation. And you can see this is from our also published paper, how this evaluation usually takes place. We start with phase 1, very extensive evaluation, which includes here video EEG. Yeah, so we are recording EEG together with video. It can be done for a day, in 2 days, as long as we need it. And then we can move into already MEG, magnetoencephalography. And if we get certain results, we can move into invasive recordings, such as ECoG. So you can see all 3 of those methodologies that I mentioned at the beginning, that they all can be used in this very tailored, specific epilepsy protocol. So, and you see that invasiveness is growing, starting from non-invasive EEG going into ECoG. And if you look at the variety of methods that we can use for studying brain activity, we can divide them into electromagnetic here on the right and metabolic. Yes. So for our purposes, electromagnetic are more suitable. Yes, which has and both EEG and MEG and ECoG. And if we look at their temporal and spatial resolution, we will see that EEG is somewhere with, of course, very precise temporal resolution, but not so good spatial resolution. Of course, I'm not talking about new developments, yes, like GTEx, pangolin, so conventional EEG. And here we have a better spatial resolution if we're talking about MEG and even ECoG. Yes. So, and this is how we will see their unique contribution will be used. And you can see here the recording of EEG, of MEG, special device, and already ECoG, when we will be placing electrodes directly on the brain. You can see that if we combine CT, which gives us positions of these strips and grids that we're placing on the surface of the brain, we can get this nice 3D model with the positions of all grids and strips, and of course we can use patient's MRI to create this model. And it was quite popular to use only those strips and grids. However, now we have also this penetrating electrodes or depth electrodes to record SEEG, stereo EEG. Or we can have combinations of one and so. If we also look at MEG versus EEG, what we will see that first of all, to record MEG signal, because it's so small, we need a very special approach, squids. So it's of course not a real squids, but it's superconductive quantum interference devices that can help record this very, very teeny tiny signal. And what we will be recording, magnetic field that is produced by the electric current that we have, which is based on the response of a certain number of neurons, yes, to our stimuli, or this might be also neurons that are working together, that are creating certain activity during abnormal epileptiform activity. So we can actually record both, and you can see here sensors for EEG recordings and electrodes, yes, in pink, and sensors for MEG. So we can do this simultaneous recording of one and another activity. So let's get back to the girl. What we did, first of all, we recorded not just EEG, yes, but we recorded video EEG, which meant that we were recording what was happening with her together with recording her EEG activity. So let's have a look at what we found. If you look here, there is a difference, yes, of what is happening before, for example, here, and what is happening in this area that I highlighted. So these are diffused bilateral rhythmic spikes with frontal dominance. If you look at the frontal electrodes, so with the frontal dominance, but it's kind of diffused, yes, if you look. It goes through many electrodes. And what information did this provide to us? First of all, that, yes, there is something. Yes, something is happening with the brain. For some reason, appear those rhythmic spikes with frontal dominance. And what was very interesting, what that video portion of EEG added to us, yes, that we were able to see what happens behavior with this patient. And it was so interesting that these abnormal spikes, they appeared at those particular time when the patient was having this symptom, those specific symptoms when she was crying and clinging to her mom, when was this uncontrollable behavior on her side. So this all was happening during this abnormal activity, which again was telling that there is something that is going on, and probably this activity in the brain is causing those symptoms. And that, together with the other information that we received, but this was a very important part of it, she was diagnosed with epilepsy, yes, neurological disorder caused by malfunctioning nerve cell activity in the brain. And usually, this epilepsy can be treated by anti-epileptic drugs, AEDs. However, it's also important to say that there are about 20–30% of patients that cannot be helped with anti-epileptic drugs. And for those particular patients, there are other procedures that are performed specifically. This can be epilepsy surgery, removal of the tissue from the brain that causes those seizures. And this was her diagnosis, yes. And so actually she was initially misdiagnosed. So panic attacks was a misdiagnosis. In fact, she had an epilepsy. And what helped us to capture that was that specific protocol that we used and EEG that was combined together with the video recording of patient behavior. So is it enough for her? Now she started to get correct medication to alleviate her seizures, which was causing this strange behavior. However, we still didn't know where exactly those seizures originate. And this was time for magnetoencephalography. Yes, so if you remember where is the spatial resolution of EEG, yes, it's not that good. However, the spatial resolution of MEG is much better. And you can see here results in yellow, which are showing us that what MEG, what information MEG provided. Yeah, so we still see frontal areas. However, we see already a clear localization of this abnormal activity. Yes, so of course here we're combining both MRI and MEG. Yes, and this provides us with this very, very precise information. So what did we get? We now see that it's a frontal area, and not just frontal area. MEG allowed us to see that actually it's a cingulate gyrus. Yeah, so this patient had a cingulate gyrus epilepsy. And you can see the difference between results from just EEG and MEG. Yes, so EEG, just frontal, diffused, and MEG, very clearly right cingulate gyrus. And this explained in a way her symptoms, why she was crying, why she had this emotional behavior, because this is how cingulate gyrus epilepsy shows itself. Yes, and she was diagnosed with right anterior cingulate gyrus epilepsy, and there was proposed a two-step surgery, so surgery that needed to be performed for this patient. And here we come to our third methodology that we talked about, electrocardiography, which is that last step in the pre-surgical work. And why do we need it? Because even we have this precise and wonderful information from MEG, it's still not enough for us to really perform the surgery, to localize a place where the seizures are originating, where they're coming from, and also for other purposes that I will talk about. So as you see, each method has its unique contribution and time and place where it needs to be used. So let's look what happened. And I want you to remember how what you saw here, yes, in EEG, how diffused was this activity. Now let's see at the same recording with the same patient, but now with ECoG, electrocardiography. So here, how we can localize already this abnormal activity at times when our patient has seizures. Yes, so it compared with the previous results that I just showed you, you can see that it's really, really very localized. And we now can really dial in on or zoom in on that specific area that needs to be removed. So is it always like this? Can we always localize so precisely? Of course not. And there are some cases when we need to implant electrodes on both sides of the brain bilaterally, like you see here, and perform an additional procedure. This is also one of publications, additional procedure which is called corpus callosotomy, in order for us to localize that abnormal brain activity. And here you can see an example of that. So on the left, A1 picture, it's when the activity is being recorded from both hemispheres with ECoG, and you see that it's difficult to see, is it really left or is it right? Yes, right in blue, left in red. So we really cannot localize where exactly the seizures are coming from, where the surgeon should go in and remove that abnormal substrate of this epileptiform activity. However, after we perform corpus callosotomy, and basically we cut that main junction between two hemispheres, this is what happens. And so now you see that there is a localization specifically in the right hemisphere. So there is nothing on the left. And so now we can start focusing already on the right. And here is another patient, A3, and you can see a similar situation. There is activity on both left and right, or right in blue, left, red. And after corpus callosotomy, we see that there is almost nothing on the left, and main activity was on the right. So that abnormal activity was very quickly propagating from one hemisphere to another, and that's why we were not able to detect or to localize it very specifically. But with certain procedures like this, corpus callosotomy, we were able to do this. And again, this was possible only with ECoG. There is no possibility to, at least in these patients, yes, in these specific patients, to do it with either EEG or MEG. So now that we know, say, where is that abnormal activity that needs to be removed, the substrate that generates it needs to be removed, we can mark it certain way. That's just symbolic representation, yes, of how we can mark it. And then we can remove it, and you can see here on the right already the same areas. Yes, so it's the same brain, just already after this surgery. And both places, those both places were the surgery. However, if we look and knowing the anatomy and physiology, we know that many areas of the brain, not many, all areas of the brain, yes, they're responsible for something, for certain function. And there are certain areas of the brain that are absolutely essential, yes, for that function. And this can be a sensory motor area. This can be area responsible for speech. Yes, the Broca, so-called Broca's area. Broca, or this can be an area responsible for speech comprehension, how we understand what somebody is telling us. And this is so-called Wernicke's area. So this is the Wernicke who first described it. And again, you know, vision. Yes, for our vision. So hello. So all of that, if the seizure onset zone, that abnormal substrate that we need to remove, if it overlaps with any of those functional areas, the patient after surgery will have a deficit. He might not be able to walk or use their hand. They may not be able to speak or understand what we're talking. And so, dependent on where there is this overlap, the patient might develop deficits. So, here is an example of how this can happen and how it's important to really perform so-called functional mapping. Yes, create functional maps of the brain so that we would be able to really do the surgery in such a way that that we can avoid touching or removing those essential areas for certain functions. And you can see here seizure onset zone in yellow, and here is the functional area, motor area in green. Yes, and there is an overlap. So it was so very important to see where is that overlap and perform a surgery. So here you can see the line where the surgery was performed and what area was left. In this case, the patient didn't develop any post-surgical complications, any post-surgical deficit. So, and this is even more important for language. Yes, if here we can use, some anatomical landmarks, yes, to identify where is the motor, where is sensory area, which is pretty similar from one patient to another, although it still varies. So the variation in language localization is even more dramatic. And why is that? Because there is a language reorganization. In epilepsy, and the same it happens in tumor patients, especially if tumors are developing for a long time. And here you can see, so usually we would expect to have an activation for picture naming task and having Broca's activation. So our expressive language, yes, to be on the left and to have very minimal activation on the right. However, if you see here is the activation for a patient, we look at the left hemisphere, there is almost no activation. Yes, however, on the right, there is a striking activation in the vicinity of Broca's areas. So, and this is the case for many patients who have epilepsy. So there are studies that show the percentage of those patients, but it's very often. So we need to really focus on nailing down those areas of the brain that are responsible for language and speech and comprehension to avoid post-surgical deficits. And of course, because of that, people always worked on finding out or coming up with the new methodologies to help with that and to create functional maps of the brain. And among those are WADA tests. It helps us to look at the lateralization. Is it activity on the left or is it on the right? It is navigate transcranial magnetic stimulation is currently used, fMRI, magnetoencephalography, electrocorticography, and there is one method here, it is in red, electrical cortical stimulation mapping, or ECS. Some people also call it ESM, electrical stimulation mapping. So, and if we look, if we could put all those methods together, yes, we very often might have quite a complicated situation like here. So in black are spikes that we see, so which we found out with MEG, with magnetoencephalography, and now we are trying to detect, so what's going on, where is the functional area, yes, and we're trying to MRI here, we're trying to G, and so on and so forth, and it's very difficult sometimes to really make sense of what is happening, but we see that probably this arcuate fasciculus, probably this is Broca's, probably this Wernicke's, yes, but how far, how close it is from the area of interest, it's fairly difficult to say, but actually here it's, this is, I'm saying, I will tell more in the future, but this is one of the methods that is now available by and done by GTEC. CAR-TQ method based on high gamma mapping. In this case, it provided very precise results and showed that there is some activation that is in the vicinity of MEG spikes. Yes, so some relevant language areas. But it's still a question, yes, what to choose, whom to believe, which method is correct. And that's why still to this day, we consider one method, which is this electrical cortical stimulation mapping, as a gold standard. Yes, so it might change in the future, but at the moment, this is what we are using. And what it means, what does it mean, electrical cortical stimulation mapping? It means that we're stimulating with electricity pairs of different electrodes, electrode pairs. Yes, and when we're stimulating pairs of electrodes, of course, we're affecting with the current the tissue underneath those electrodes. And we can cause various behavioral symptoms dependent on what area is being covered by those electrodes. Yeah, so if it is motor area, then we will observe a twitch of a hand of a patient. If it is language area, let's say speech, a person might stop speaking suddenly. So all this is might happen. So various symptoms dependent on the area. And although we tend to trust the method, so it provides us with the fairly reliable results, there are many drawbacks. So it's a method that has been used for many, many, many years already. And the main drawbacks, first of all, the method is fairly slow. Because we need to test all the pairs of the electrodes, yes, or majority of the pairs, and then we need to make sure that that behavioral response was caused not by anything else, but by our stimulation. Maybe if the person stopped speaking, he just dozed off, yes, or maybe he responded to something that was happening. Yes, maybe he paused to listen to something. Maybe he was disturbed by something. So there can be always something that caused the behavior, not necessarily our stimulation. So we need to repeat this. And imagine right now there is a tendency of using more and more electrodes, sometimes 88, 256, and whatnot. So, and imagine testing so many pairs of those electrodes and repeating it, and sometimes you don't get the response. You need to increase the intensity of the stimulation and repeat it over. So it's really, really tedious and a long process. And the most important, that this method often causes seizures. Not that often, of course, it's not very high percentage, but it happens. And we had situations when the person cannot undergo this procedure because each time we're trying to stimulate, the person has seizures. Yeah, so those are main drawbacks. And because of that, there was a push to develop a new method, new approach that can help us to alleviate all those difficulties. And this already where our ECoG started to help us. Yeah, so we can use the same information from the electrodes that are implanted in the brain, but we don't need to stimulate them. We just simply record the signal, and we are still recording a signal to detect where the seizures are coming from, but we also can output this information into our so-called separate functional mapping arm. Sometimes we call it the research arm, because you also can do amazing research with that. And this is what we initially used, GTEC amplifiers. At that time, we had 8 of them. However, right now we have amazing solution from GTEC that incorporates all of that, and we can record from more than 200 leads, 200 electrodes at the same time, 256, I think. So we can have the signal recorded separately, and we can present the person with a certain task. All the fMRI tasks work here. It's a block design, so we have control condition and active condition. For example, very famous task, picture naming, when we ask a patient to present a picture. Yes, so we present the picture, and then the person just looks at the screen, and then we present the picture and the person looks at the screen. So any type of these paradigms can be used, and we are comparing what happens during this control condition versus active condition. These are some examples of stories. So this is for comprehension. We also can use, and what happens? It happens that there is a change in high gamma range from 70 to 110, 130, 170 hertz, and change in the power of the signal. So if you look at the resting period at that control condition, it's in green. Yes, and when there is active condition, when the person is listening to stories or naming pictures, it's in red. So there is increase in power, and we can use this information without any stimulation to really map where are those areas of the brain that are involved in task. And we demonstrated successfully that we can use this method for lateralization. So we can say, okay, language is lateralized to left or to the right, which is the first step for us, because if we know that the language is not lateralized to the left, we can perform a surgery on the left. Yes, so where we don't need to worry about that. But if it is in the left, if the language is lateralized to the left, then the next question is where in the left? And here we already need to work on localization. Yes, and here we show that with this particular approach, we can successfully localize the areas in the brain. So here you can see the results, initial results. Here is the Wernicke's areas, here is the Broca, and they are concordant with fMRI results, and even more so with the electrical cortical stimulation results with that gold standard. So this is what ECoG can provide to us. Not only seizure localization, but it can provide us with the maps of the brain. And not only that, but we can use it to predict post-surgical language outcomes. And if we are removing certain areas that we showed that are involved in a function, and we did it with this high gamma approach, we might expect to have deficits, which we also demonstrate. So there are many good things about that, and we can high gamma mapping has high predictive value. It adds information, so additive value, because here we don't need to go pair by pair. We have all the information together. Yes, that was not possible just with the cortical stimulation. For example, here, so we get a vast information about everything that is happening in the brain in a very, very fast fashion. There is only one problem, that still the sensitivity and specificity of this method when compared to gold standard not still very high. Yes, it depends on the modality. For motor mapping is pretty high. However, for language is still not yet, not there yet. Yes, so still very low accuracy compared to gold standard. And there are different ways to deal with them, with this, and we will hear more. So this is just brief overview, because we will hear more about this on the day, I think, 5, or then day 9. Yes, day 9 of our school. But that's why I'm not getting into the details, but I just would like to talk about the study that I did together with the team of Dr. Ulas Bakci at UCF, where how we were trying to mitigate this low sensitivity and specificity. We were trying to create a method that combines information from both stimulation mapping and ECoG mapping to create a so-called cortical stimulation machine learning guide, yes, for functional mapping, which and we used both random forest classifier. We also worked with deep learning, and we show that this both accuracy, sensitivity, and specificity when using those methods can be improved. So here is a conventional approach. The use of random forest classifier and deep learning provided the best results. So it's all possible. Yeah, so we have a really robust method, and now with different variations, tweaks, combinations, we can bring it to the level where it really can serve us well. And of course, including various other higher frequencies, which is also very important. So we'll not stop on that. And also very important, because there is a shift towards not only grids, but those SEG electrodes that I mentioned at the beginning. Yes, we are also seeing research and tools, like, for example, GTEC provides with the GBS Analyze extension to do this mapping and for stereo EEG for those implanted electrodes. And you will hear more about it in the future talks. So how we can use those combinations. First of all, for example, if we want to implant, yes, the electrodes for P300 applications, for any other applications, yes, from non-invasive to invasive, how to do that? We can use MEG. For the mapping of those precise locations where we need to implant the electrodes. And this is again the work that we showed. So we mapped with MEG, and we were able to localize the electrodes that had the highest P300 response. Yes, so those areas then were used with the ECoG to record ECoG, and we had, which you can see over here, and we had very good P300 speller results. So I have a brief video, but I will not be showing it already with our patient spelling with a very high speed. Yes, so here you can see P300 speller performance accuracy by that patient. So who is the winner? Yes, ECoG, EEG, or MEG? So what would you say after we talked about that? So I don't think we can really say which one. Yes, each of those methods, and I hope you were able to see it from what I demonstrated, that each of those methods has their unique contribution that the method has to offer. So it really depends on the need of what we need at the moment, and we can choose the method that will help us best, or we can combine several methods together, like here in MEG and ECoG. Yes, one is helping and so on and so forth. So with invasive, more people are willing to have the implantation, for example. Yes, but we're going towards minimally invasive surgeries. For EEG, it's good for daily use. It's a wearable technology. Again, EEG, GTEC has a beautiful wearable EEG headsets that can be used. MEG provides new non-invasive opportunities in terms of spatial and temporal resolution. Yes, non-invasive. So what can we expect if we are looking into the future? First of all, what new developments we can expect? And in all those methodologies and how they can, how else they can be used. First of all, there is a new push towards looking at the higher frequencies. And I showed this in our study with Dr. Ulas Bakchi when we really looked at the high frequency activity. And this is our review paper that was published like almost 9 years ago, where we talked about that, but it wasn't that popular. But there is a research that is showing that we can study high frequency oscillations in a very, very high ranges, and we can do it both with MEG and also with ECoG. And actually, there are new solutions, and this is again new developments by GTEC. I encourage you to listen to Mustafa Mahadapour from GTEC, who will be talking about this. And this is automatic detection of high frequency oscillations that go definitely beyond usually used frequencies, yes, for seizure detection. So this is really something that is becoming very popular and can help clinicians tremendously in their work. So that's number one. Number two, something that, again, ECoG or EEG cannot do, but MEG can do, and this is fetal magnetoencephalography. So it's a non-invasive method for investigating evoked brain responses and spontaneous brain activity generated by the fetus in utero. So can we communicate with the fetus via MEG BCI system? That's something interesting to explore. Yeah, so this is how it's now done. This was done before with the cardiomagnetoencephalography, with the magnetocardiography. Yes, and now there are devices already that can do it. Specifically developed devices for that, and it helps to detect abnormal epileptiform activity already in utero. For pre-surgical workup, there is a high correlation between what we see in MEG here on the right and high gamma mapping. Yes, so maybe MEG can be used as a guide for language localization and also for passive recording. So not necessarily even the patient needs to participate in this type of recording, especially if it's a little a young child, yes, or if this a person who cannot participate in active task for one or another reason. And of course, new development in ECoG, and here is CartiQ mapping, including not just block design like we had, like I showed you, but event-related mapping, which can provide us what happens in time and can provide us with the new possibilities for mapping certain functions. So like here. Then mapping of other areas of the brain. Here is the study from Israel, who were mapping, for example, functional areas of the foot, yes, or other areas of the leg. So we're expanding what we can map with this high gamma mapping with CartiQ. And of course, various applications for BCIs, real-time MEG systems, and there are studies that are showing that we can use it for neurorehabilitation, for example, and we can use all three methodologies if we need for rehabilitation. So this is a new approach when we can anticipate already certain damage that will be done to the brain if there is a certain substrate that needs to be removed, like here, and it involves motor areas because it just produces seizures, and there is no other way to stop them. Yes, so in this case, the area is removed, and we know that it will be removed. So maybe we can do rehabilitation of transferring, or rehabilitation of transferring the function to a different area of the brain. Yes, and here we can use both ECoG and EEG and the MEG. All at the same time. Of course, there are obstacles. For example, for MEG, it's bulky, we cannot move it, and that's why applications are obscure, especially for BCIs. However, there are already new generations of MEG sensors and their wearable, so that's another possibility. So no more using squids, so but there are OPM, optically pumped magnetometers, and a new possibilities for EEG. If you remember at the beginning, we were showing that it just gives us this diffuse picture. Sometimes that we really cannot do localization. Of course, in some cases possible, but in some absolutely not. However, new developments like we have here in GTEC, yes, they allow for ultra high density EEG recording, which already show that we can identify even central sulcus by using this approach, yes, or decode individual finger movement. So we can create functional maps of the brain with this ultra high density approach. So this is another direction that I think we all will be moving in the future. So exciting developments, and I'm really looking forward to seeing how all this will turn out and will help our patients and clinicians also to do their work. So thank you very much, and I would like you all to listen to our podcast and participate if you want to share your stories. And we started with number 1 several years ago with Christoph Guger being our first podcast guest. And now we're already on episode 82. So this is the last episode about the stage fright and how we can what we can do to alleviate it, and this again with the brain imaging approaches. And why I added this specific episode, because it's last, and because although I gave probably at least around 100 talks already in my life, I still, each time I cannot sleep before I talk. Before I need to talk, and I have a severe anxiety. So I think new developments with the neurotech will help all of us to alleviate all those unpleasant things. And also, please listen to the BCI Award podcast and submit your work for our BCI GTEC BCI Award. So thank you so much. It was a great pleasure to be here. And I will be happy to answer your questions.
Thank you very much, Milena. Very nice presentation. And yeah, it's amazing that you already got 82 podcasts recorded. Very nice work. Muhammad is asking, does substral analysis qualify as a unique feature extraction for ECoG? Higher order statistics, the substrom, for example, higher order statistics. Do you know if this would be useful as feature extraction for ECoG?
I haven't used this as a feature extraction for ECoG, but I definitely can look into that. And if you contact me, I will be happy to answer you in email.
Actually, these higher order statistic algorithms are very nice if the signals contain a lot of noise. So they are especially qualifying for EEG data because it's much more noisy than ECoG. But of course, it's also possible to apply it on ECoG data. And you can also register for one of the data sets in the hackathon because we have ECoG data sets inside, and then you can test your algorithms right away there. And Milena, you showed an example of a 5-year-old child.
Yes.
And somebody's asking if this child was born with a C-section, and was she or he in the ICU?
No, we didn't have that information, but from what we knew, so there were no development problems with child. Yes.
And then Manuel spoke also with Dr. Babiloni, and he wants to know if you think there might be a functional difference between left-handed and right-handed people, and the difference in behavior they show.
Left and right-handed, to my knowledge, I don't think so.
Did you ever study this, right-handedness and left-handedness and so on?
I had one study a long time ago, but I didn't specifically focus on that. No.
So we need other experts for these questions. I also didn't study left and right-handedness. And David is asking or saying fMRI has been successfully used for brain-machine interfacing. Do you know any studies that used MEG?
For brain-computer interfacing, yes, especially for stroke rehabilitation. That is one of the most popular uses.
Also, Niels Bierbaumer's group with Thilo Hinterberg, this also many years ago, they used also MEG decoding for brain-computer interfacing. Works nice. The main disadvantage is the big MEG device that you need. And then Asade is asking, how did you find your specific time in the EEG during which the symptoms happened?
Because we were recording synchronously both EEG and video. And we were able to see what happens exactly at that time, yes, because we had synchronized recordings of one. Yeah, so that's the main purpose of recording both.